So the universally accepted definition of this hyperkalemia is any serum potassium value that is above 5.5 milliequivalents per liter. Some textbooks do mention 6 and some 6.5, but the value anything above 5.5 is considered as hyperkalemia for all the purposes in day-to-day practice. So it's a very common medical emergency. It's not so uncommon. I think if you are practicing internal medicine, especially in a hospital-based setting, each and every day you will be seeing at least 1 or 2 patients of hyperkalemia in your wards. So whenever the hyperkalemia presents, the first important thing is to determine the acuteness and what is the bearing of this increased potassium on the body, especially the cardiac muscle and the skeletal muscle. Whenever this hyperkalemia is persistent, especially in the setting of chronic, it is usually in the background of drugs, or usually a patient is a known case of some chronic kidney disease, or there is a reduced excretion of this potassium in the kidneys. So if you see the incidence in hospital-based settings, so it ranges from 1.1 to 10%. It depends on what type of hospital setting you're practicing. If you're practicing internal-based medicine, nephrology-based medicine, I think every alternate patient you'll be seeing is with a hyperkalemia. And if you see this, the significance of this hyperkalemia, which has got highest in hospital mortality among all the dyskalemias. If you compare the hypokalemia, that the mortality is 5%, the mortality of hyperkalemia is 18%, I think, which is a very, very high. Every 20 or 80 to 20 out of 100 patients of hyperkalemia is going to die. That is a very huge number in a big hospitals. So if you see the cause of the hyperkalemia, the very two important pathomechanisms causing this hyperkalemia is, one is the increased potassium release from the cell. We know that the intracellular potassium is higher than the extracellular potassium. Potassium is the major cation which determines the positive charge of the intracellular site. The intracellular potassium is much higher compared to the extracellular. So whenever this intracellular potassium moves out into the ECF in a tremendous way, this can cause hyperkalemia. So one of the very important reason for especially acute hyperkalemia is the increased potassium released from the cells. The next most common cause is the reduced urinary potassium excretion. This is usually a cause of chronic hyperkalemia in practice. So this transcellular shift, that is extracellular shift, is usually causes acute hyperkalemia, whereas the reduced potassium excretion is a cause of chronic hyperkalemia. So if you see this increased potassium release from the cells, here the total body potassium is actually normal. Just there is a mismanagement between the transcellular shift. So in case of the reduced urinary potassium excretion, the total body potassium may actually be high, since the amount of potassium that has to be excreted normally through the kidney, which is a major organ, 90% of the potassium which we take or which is produced during the metabolism is usually excreted through the urine via kidney. So any abnormality in the reduced excretion can also cause hyperkalemia. So if you see the increased potassium release from the cells, there are many causes. One of the very important causes is the pseudo-hyperkalemia. That means it is pseudo. What happens is, here if there is an elevation of measured serum potassium, which is usually due to potassium movement out of the cells during or after the blood specimen has been drawn. Like if you are taking the specimen or the sample of the blood for some testing, if the mechanical trauma is being occurred during the venipuncture, especially you have taken the sample and you have shaken it too rigorously, which might have lysed the cells, can release the potassium and cause hyperkalemia. And if you have used the tourniquet, or if the patient has done repeated fist clenching, especially if he has done very vigorously, some over enthusiastic patients can actually lyse these RBCs or WBCs during the process of the withdrawal of the sample, can cause the hyperkalemia in the sample. And there are some actually inherited forms of this pseudo hyperkalemia, where as soon as the blood is withdrawn, the cells are going to lyse and increase the potassium in the sample. So remember here, the sample is hyperkalemic, whereas the person is not hyperkalemic. This is a very, very important thing here. The pseudo hyperkalemia is a very important thing. Whenever you have received the laboratory report of the hyperkalemia, but which is not correlating with your patient. Patient looks perfectly fine. There are no ECG changes. Patient does not have any kidney abnormalities. Patient is not on any drugs which might cause the hyperkalemia. But yet, if you're seeing hyperkalemia, so you need to repeat the sample without using these two. Like, don't use the tourniquet. Don't ask the patient to do repeated fist clenching. Take the sample very carefully. Don't shake the sample rigorously. So I have seen many interns after taking the sample, so they shake it very vigorously. That is a very wrong thing to do. You need to just tilt the vials to just mix, especially with the EDTAs, all these things. So the pseudo hyperkalemia here, actually it is not a clinical entity. It is just a technical dysfunction which can cause the hyperkalemia. Here patient does not require any treatment, as the person is not hyperkalemic. Here that particular sample is hyperkalemic. And very important cause of this hyperkalemia is metabolic acidosis. In the last class we discussed that what are the things which can cause the intracellular shift of the potassium. We know that the alkalosis causes the intracellular shift. We know that the beta agonism or any sympathetic overactivity, and insulin. These are the three very, very important things which causes intracellular shift. So opposite of these things, metabolic alkalosis can cause the extracellular shift of this potassium. Why this occurs? This occurs basically because, see, there is an intracellular potassium and there is a acidosis. That means there is too much of H plus ions in the extracellular fluid. So what body does to compensate it is it tries to take up more and more H plus ions into the cell. So we know that the electroneutrality is the rule. If one cation is coming into the cell, one cation has to go out of the cell. So we know that potassium is the major intracellular cation. So in exchange of the intracellular movement of this hydrogen ion, the potassium moves out, which can cause hyperkalemia, especially in the setting of severe metabolic acidosis. This is very, very important. But this particular acidosis is only seen with organic acidemia. This is not seen with the high anion gap metabolic acidosis. That is what lactic acidosis, the alcoholic, diabetic, or starvation ketoacidosis. All these are usually not associated with hyperkalemia. These are usually seen only with the non-anion gap metabolic acidosis. And it is not a must rule, like all the patients of metabolic acidosis should have hyperkalemia. It is not like that. Only some patients of metabolic acidosis, although exact reason is not known, can have hyperkalemia, and the main mechanism is this potassium H plus exchange. And the next most common cause is the insulin deficiency. So as I told you, that insulin causes the intracellular movement of the potassium. If the insulin is deficient, there is reduced movement of this potassium ion into the cell, so causing increase in extracellular potassium. So where this insulin deficiency you usually see, this is diabetes mellitus, isn't it? So diabetes mellitus patients can have hyperkalemia just because of insulin deficiency. So in this particular graph, after the glucose load was given to the non-diabetics, and glucose load was also given to the diabetics. So if you see, we know that if we give glucose to the patient, there is an increase in endogenous insulin secretion. So this increased endogenous insulin secretion is going to lower the potassium in normal non-diabetic patients. But in diabetic patients, since they are insulin deficient or insulin resistant, if you give a glucose load in the background of insulin deficiency, the potassium is going to increase. This is because of the hyperosmolarity caused by the glucose infusion. So hyperosmolarity with hyperglycemia in the background of insulin deficiency can cause the hyperkalemia. So if you see this triad, you might remember one particular disease that can occur in a diabetic, especially in an emergency setting, that is hyperosmolar hyperglycemic coma. So this hyperosmolar hyperglycemic coma patients usually or can have hyperkalemia when they come to hospital. We know that the diabetic ketoacidosis patients are usually potassium deficient, but the HHS patients actually may be potassium overloaded due to the reduced movement of this potassium from extracellular to the intracellular fluid. So this is very, very important. So the uncontrolled diabetic patients, especially in the background of the diabetic nephropathy, the hyporeninemic hypoaldosteronism, which has been very frequent in case of diabetes, that is because of the atrophy of the juxtaglomerular cells, which usually produces renin, is also very common in diabetes. So the diabetes uncontrolled per se can cause the hyperkalemia. This is a very important thing. This is actually a very common thing which we usually see in day-to-day practice. Many of the patients of diabetes, they have unexplained hyperkalemia in their laboratory value, which usually gets add on with the addition of the specific antihypertensive drugs, that is ACE inhibitors or ARBs, which are also the reason of this hyperkalemia. So the potassium has to be dealt separately while you are managing a patient of diabetes. This is a very, very important thing. The next endocrine thing is the somatostatin. We know somatostatin is actually a hormone produced from the pancreas, is actually a splanchnic vasodilator. We use it for the many purposes. So when somatostatin was used, this also can cause the hyperkalemia. This is because, again, this somatostatin is an insulin antagonist. So why this somatostatin is used in patients? So you might see there are some specific entities, like there is one particular disease called postprandial hypotension. Like there are some patients who are usually going to develop the postprandial hypertension. As soon as they have a meal, after 1 or 2 hours, they are going to have a hypotension due to some abnormal sympathetic innervation in the splanchnic circulation. So in these patients, we usually give somatostatin infusion to these patients. This is also true in case of the dialytic patients, where the postprandial hypertension is also very common in patients on chronic hemodialysis. And octreotide, we usually use it for the hepatorenal syndrome, all these things, like the patients of upper GI bleed, to reduce the vasodilatation, etc. So these patients can have the hyperkalemia, which is very, very important. And there is a particular entity that is fasting, prolonged fasting, especially in patients of hemodialysis, again due to the secretion of somatostatin by the endogenous pancreas, can also cause hyperkalemia in the patients. So this is very, very important. The uncontrolled diabetes per se, or uncontrolled diabetes with the background of diabetic nephropathy, or the hyperosmolarity in the setting of an emergency, and some patients where the somatostatin is given exogenously or an increased somatostatin from the endogenous pancreas, that is fasting, can cause the hyperkalemia in the patients. Then increased tissue catabolism, that cell lysis of any kind, can cause hyperkalemia. I think this is very simple to understand, because as the potassium is being stored in the intracellular organelles, so whenever the cell gets lysed, whatever the potassium is there is going to come into the extracellular fluid. So this is very common in case of tumor lysis syndrome. This tumor lysis syndrome can occur per se, especially in cancers with a heavy cell load, like Burkitt's lymphoma, leukemias, all these things. And when the patient of cancer started on chemotherapy, this tumor lysis syndrome is very, very common. So here we usually see that patient usually have hyperkalemia, hyperuricemia, hyperphosphatemia, and hypocalcemia. So where this released uric acid is going to deposit in the kidney, causing acute kidney injury. So all this is a very important emergencies associated with the malignancies. Then any acute intravascular hemolysis, you may see any drug induced or any infection induced, all these things, mechanical valve induced intravascular thrombosis or hemolysis, can cause the sudden release of potassium into the extracellular fluid. And again, rhabdomyolysis, the lysis of the muscle cell, this can be due to ischemia, this can be due to drugs, anything of rhabdomyolysis, where the myoglobin along with the potassium gets released into the extracellular fluid. So this potassium is going to cause severe hyperkalemia, and this myoglobinuria, we know that it is very toxic to the kidney, is going to cause the acute tubular necrosis. So all this together can become deadly in the patients. And acute transfusion reactions, whenever there is an ABO incompatibility or RHO incompatibility exists during the transfusion, this can cause the transfusion reaction due to hemolysis again. And whenever there is an hemolysis within the large hematomas or the hemangiomas, like a big hemangioma which has been situated in the liver, kidney, or in the brain, if there is an excessive hemolysis inside this, can also cause the hyperkalemia. And acute ischemic colonic necrosis, we know that colon cells are very important or very rich in potassium because they usually secrete this potassium into the stool. So among all the tissue or organ necrosis, it is the colon necrosis or mesenteric ischemia which has been very notorious in causing hyperkalemia. So I think I have seen 1 or 2 patients where the hyperkalemia was unexplained of the any causes of the above, when the patient is repeatedly going to have the pain abdomen, especially the postprandial pain abdomen, which is very common in ischemia, when the patient can have diarrhea, patient can have the red hematochezia, all these kind of presentations. You need to suspect this colonic ischemia in the patient. And hypothermia, again due to cell death or cell lysis, can cause the hyperkalemia. Last class we also discussed that hypothermia is one particular entity where it can cause both hypokalemia and hyperkalemia. The hypothermia causing hypokalemia, the exact reason is not known, whereas hypothermia can cause hyperkalemia by cell lysis. So you need to anticipate the potassium in hypothermia. It can be either hypo or hyper, depending on the patient. Next, the very important drugs are beta blockers. We know that beta agonism is very important in moving the potassium into the cell. Any kind of the beta antagonism, that is beta blockers, especially the non-selective beta blockers. What are the non-selective beta blockers you know of? That is propranolol, which has been rarely used nowadays, only used in case of the migraine prophylaxis or the other calcium overdose, all these things, the propranolol is used. Otherwise, it is rarely used nowadays. Other non-cardioselective are the cardiovas and the cardiovas means carvedilol and the labetalol. There is some amount of non-selectivity among all these 3 beta blockers, which can cause the beta blockers, especially the carvedilol is being very commonly used nowadays in case of chronic heart failure. So carvedilol induced hyperkalemia has also increased recently. So the non-selective beta blockers, by directly inhibiting the sodium potassium ATPase, can cause the hyperkalemia. Again, the drugs like the succinylcholine and the digoxin are very notorious in causing hyperkalemia. We know because digoxin, again, it inhibits sodium potassium ATPase. Succinylcholine is very important. It can cause the hyperkalemia in the patient. And very important other mechanism is, we know that succinylcholine acts on the acetylcholine receptor. So whenever we give the patient of the acetylcholine receptor, we know these acetylcholine receptors are situated in the muscle end plate. That is where the neuron comes and ends. That is called as myoneural junction. So whenever we give the succinylcholine to the patient, these whatever the acetylcholine receptors which are stored inside the cell gets released and bound to the cell, not only in the myoneural junction, but on the entire muscle surface. So this can cause the excessive stimulation of this acetylcholine receptor, causing persistent depolarization of cells. So this is also true for a cardiac muscle. So that's why you might have seen many patients of the succinylcholine when you used it for an emergency intubation. If you're not checked the potassium in the background, these patients can go into the asystole in a very rapid way. It is very common thing to see in emergency where patient have extubated the tube and he's behaving rigorously or vigorously, he's withdrawing his tube, everything. You again wants to sedate the patient, so you just order the sister to give succinylcholine or to push succinylcholine. So just you push the succinylcholine, within 1 or 2 seconds patient go into asystole. So this is very common if you are not checked the potassium in the background. So this succinylcholine induced asystole is irreversible. This is because very important. I have not seen any patient who after receiving succinylcholine going into asystole coming back to the normal sinus rhythm. This is very common a mistake which everybody do. So whenever the patient is at risk of the having hyperkalemia in the background, even if you have not checked the potassium, just don't use succinylcholine, use other muscle relaxants in the practice. You can use atracurarium, you can use the rocunarium, all these things, but not succinylcholine, a very, very important thing. And exercise, again, exercise can cause the progressive hyperkalemia as the exercise intensity increases. The exact reason for this is not known. The most popular hypothesis is the sodium potassium ATPase pump. It cannot pace with the potassium efflux from the muscle depolarization and repolarization process. We know that there is a depolarization and repolarization occurring during the exercise. So potassium is very, very important during the muscle exercise, because this potassium which is getting released from this potassium efflux is a very potent stimulator of the vasodilatation, which is very, very important during exercise. The muscle wants or muscle needs more and more blood to come to that particular muscle during exercise. So this being brought up by the vasodilatation, again, the main reason for vasodilatation during exercise is the potassium. We know that hypokalemia, in the hypokalemia, this potassium secretion cannot occur, so the vasodilatation cannot occur. So exercise-induced rhabdomyolysis or exercise-induced ischemic rhabdomyolysis is very, very common in case of hypokalemia, whereas the hyperkalemia is very common in case of the persistent exercise due to excessive efflux of this potassium. And hyperkalemic periodic paralysis, we know that this is a rare entity where there is this is actually a channelopathy due to abnormality in the sodium channels, which can cause the hyperkalemic periodic paralysis. So this can cause the intermittent or the episodic paralysis, which is associated with the elevated potassium levels. So where the episodes are brought up by the rest, or the rest followed by the exercise, or the steroids, all these can bring out this episode of the episodic paralysis. We know to remember the channel defects, the hypokalemic periodic paralysis and hyperkalemic periodic paralysis. The hypokalemic periodic paralysis is due to calcium channel defect. The hyperkalemic periodic paralysis is due to sodium channel defect. And one mnemonic which I used to remember during the entrance time is, this is O, so this is C. So C means half O. So hypo for calcium, hyper for sodium. So I think this is a very common question which usually keeps on coming during the entrance question, like what is the channel which has been defective in hypokalemic periodic paralysis or hyperkalemic periodic paralysis. So this is very, very important. In none of these channels, the potassium channel is defective. In hypokalemic, it is calcium channel defect. In hyperkalemic, it is the sodium channel defect. There are other reasons for this transcellular shift of this potassium. One of the very, very important reason is the solvent drag effect, that whenever the osmolarity of the blood or the extracellular fluid gets increased, the water moves from the intracellular compartment to the extracellular compartment. So this excessive water, which while moving also takes up the potassium during the movement. So any amount of osmolarity or hyperosmolarity in the extracellular fluid can cause hyperkalemia. So this can be seen when the patient is getting injected with a lot of mannitol, the hypertonic saline or IVIG. So these are some unexplained causes of hyperkalemia in your patient. You need to be careful. And the fluoride poisoning is also a very, very common. The exact reason for these are unknown. And arginine, this is also very, very important, because you might have heard this particular drug, that is LOLA, L-ornithine L-aspartate. This is a very commonly used drug in a practice, medical practice, for hepatic dysfunction, especially in the background of hepatic encephalopathy. They are being used as the essential amino acids to used as a hepatosafe drugs. So this ornithine infusion, arginine and ornithine infusion can cause the hyperkalemia in the patient. So this is also a very, very important, because these patients of hepatic dysfunction can also have a background of hepatorenal syndrome, in the back, where this acute kidney injury along with the hepatic dysfunction can precipitate the hyperkalemia when you give the patient the aspartate. So you might have seen, or if you're not seen, you might see many patients after giving Lola may actually worsen with their hepatic encephalopathy. That is because of the hyperkalemia which is occurring in these patients. We know that any amount of dyskalemia is going to increase the hepatic encephalopathy, whether it is hyperkalemia or hypokalemia, is going to increase the severity of hepatic encephalopathy. So we have seen many patients of this hepatic encephalopathy where after giving the Lola are going to worsen from grade 2 to grade 4 or becoming ventilator dependent because of this arginine infusion, which has to be kept in mind. Again, another amino acid lysine can also cause this hyperkalemia by the unknown reason. And ESA, that is epsilon amino capnoic acid, which is used as an anticoagulant, can also cause this hyperkalemia due to unknown reason. So we know that the most common cause of this acute hypercalcemia is the increased potassium released from the cells. Among that, the pseudo-hyperkalemia is a laboratory error, or which is due to during the errors in the process of withdrawing the blood. Other most common reasons are the uncontrolled diabetes or any amount of insulin deficiency, especially in the background of hyperosmolarity. Then the beta blockers are the very, very important drugs, and the hyperkalemic periodic paralysis. These are the very important things which you should remember. Along with that, the non-anion gap metabolic acidosis sometimes can have the hyperkalemia, but not the patients of diabetic ketoacidosis and the lactic acidosis. The next most common cause of this hyperkalemia, or the clinically very, very important thing, is the reduced urinary potassium excretion. So we know that whatever the amount of potassium we consume in the daily fluid is getting used in the daily metabolism. Whenever there is an excess which is elevated in the serum, is going to compensate by the increased excretion of this potassium in the urine. So if this excretion of this urinary potassium is reduced, then it is a very important reason for the hyperkalemia, especially the chronic or persistent hyperkalemia. So if you see the causes of this hyperkalemia, the very, very important is renal insufficiency. Whether it is an acute renal insufficiency or a chronic renal insufficiency, hyperkalemia can occur, especially the chronic renal insufficiency, that is CKD. Whenever there is a progressive drop in the GFR due to low distal sodium delivery, the amount of filtration itself is low. We know that whatever the amount of the solutes are there in the blood, which are going to get filtered in the glomerulus, this filtration itself is not going to occur, causing low distal sodium delivery and potassium delivery. So potassium secretion is being not getting done, and potassium filtration is not being done in the glomerulus. So the reduced GFR, especially the end stage kidney disease, that is GFR less than 15, with a very low urine flow, that is in the background of oliguria, is a very, very important reason and a very common reason in day-to-day practice. Especially these patients are chronically hyperkalemic. I still remember one of my patients during my PG time, he was also HCV positive, hepatitis C positive, used to come for the weekly twice dialysis. I never saw his his potassium below 6 in my entire 3-year PG practice. His potassium used to be always more than the 6 or 7, in spite of the regular dialysis and the potassium binding resins which he used to receive. So the reduced GFR, especially CKD, is a very, very common and important reason for hyperkalemia. If you see acute kidney injury, the oliguric acute kidney injury is more common to have the hyperkalemia than non-oliguric AKI. So these are very, very important reasons of the hyperkalemia, chronic hyperkalemia. And sometimes you see that hyperkalemia may be disproportionate to the drop in the GFR. Like if you see the GFR is pretty good. It is actually 45 to 60. Patient is in a still stage 3-4 CKD, but yet he is developing recurrent or persistent hyperkalemia. Then you need to suspect the tubular abnormality, that is tubulointerstitial diseases that particularly affects the distal nephron is being suspected in these patients. So in some conditions like the amyloidosis or the sickle cell anemia, the interstitial nephropathy or obstructive uropathy. So in these patients, even though there is GFR is pretty well maintained, the hyperkalemia can be very severe. So this has to be remembered in your practice. Like if you see, amyloidosis is a very common cause of this chronic kidney disease and the nephrotic syndrome. These patients are very notorious to have persistent hyperkalemia. Again, sickle cell anemia. Another reason for sickle cell anemia patient having hyperkalemia is the type 4 RTA, which usually develops in these patients. And interstitial nephropathy, obstructive uropathy due to tubular dysfunction. So these principal cells in the collecting ducts are not able to secrete this potassium, so can cause hyperkalemia disproportionate to the drop in the GFR. So this is very important. Then apart from the chronic kidney disease, there are very important reason are the drugs which interferes with the urinary potassium excretion. And one of the very important drugs are the spironolactone and the amiloride. We know that the spironolactone acts on the mineralocorticoid receptor situated on the principal cell nuclear receptor, which induces the sodium absorption and the potassium secretion. So whenever this action is being not done, so there is sodium wasting and there is no potassium secretion. That's why these patients are going to have the hyperkalemia. Spironolactone is very notorious in causing the hyperkalemia. Again, amiloride is the direct blocker of this channel called ENaC, that is epithelial sodium channel. In the last class, we understood the role of ENaC in potassium secretion. So this amiloride is a direct agent which blocks ENaC. So this can cause hyperkalemia in the patient. Again, ACE inhibitors and ARBs are very important. We know this ACE inhibitors are the drugs which normally inhibits the conversion of this angiotensin 1 to angiotensin 2. We know that the normal in the body, after the renin secretion, this renin is going to produce angiotensin 1, and this angiotensin 1 is getting converted into angiotensin 2 by enzyme called angiotensin converting enzyme, where this angiotensin is going to have multiple actions based on this receptor, that is angiotensin receptor. So whenever this angiotensin converting enzyme inhibitors are given or angiotensin receptor blockers are given, so these can cause the hyperkalemia in the patient. So this is a very important. So we know that the nowadays the chronic heart failure therapy, the ACE inhibitors and ARBs are the background of the prevention of the cardiac remodeling. So these ACE inhibitors are very important antihypertensives. The ACE inhibitors are very important cardiosafe drugs. The ACE inhibitors and ARBs are very important antiproteinuric drugs, which are most commonly used in day-to-day practices, can cause hyperkalemia. So this is usually dose-dependent action. And whenever you start the patient on ACE inhibitors or ARBs, you need to have the eye on the potassium. That is very important. Again, beta blockers, in the few minutes back, we discussed how the beta blockers, especially the non-selective beta blockers like propranolol, carvedilol, and labetalol, cause hyperkalemia. And cyclosporine and tacrolimus, by directly reducing the potassium secretion in the cells and also by reducing the renin secretion and some multiple mechanism of action, these can cause the hyperkalemia. Why these drugs are being separately mentioned? This is because we know that cyclosporine and tacrolimus are the backbone of the immunosuppressive therapy, which we usually give after kidney transplantation. So these drugs are very important in causing hyperkalemia. So in some patients, even after having kidney transplantation, hyperkalemia is not leaving them behind because of the use of tacrolimus and cyclosporine. This is very important. Sometimes the patient might be shifted to other immunosuppressive drugs because of persistent hyperkalemia caused by cyclosporine and tacrolimus. Then some anti-infective drugs like the trimethoprim and pentamidine. We know that pentamidine is a drug which is used for the toxoplasma and all these things can cause hyperkalemia, and tripithoprim or tubulotoxic drugs can cause the hyperkalemia. Again, NSAIDs are very important drugs. So these actually reduces the prostaglandin secretion in the efferent arterioles by reducing the renin secretion. So for renin secretion, the prostaglandin production is very, very important. So whenever the prostaglandin production is being inhibited by the NSAIDs, this is again going to cause the reduced renin production. So this reduced renin production again is going to cause the hyporeninemia. So this can cause the hyperkalemia in the patient. Heparin, special drug which can cause hyperkalemia because it is a direct adrenal toxic. We know that along with the ketoconazole, oriconazole, this heparin is also an antagonist which acts on the direct adrenal gland to reduce this mineralocorticoid synthesis. So heparin, especially the low molecular weight heparin, which we usually prefer for the IV route, can cause the hyperkalemia, although low molecular weight heparin is known for causing hyperkalemia in the patients. So in the exams, the drugs-based questions are very, very important. They tend to give some 4 or 5 drugs and ask which of the drugs does not cause hyperkalemia and all these things. So while you are studying for hyperkalemia, the drugs causing hyperkalemia is very, very important, because in day-to-day practice, apart from the CKD, the next most common cause which we usually encounter is the drug-induced hyperkalemia. Because you see, we know if you read in heart failure management, are the drugs which reduces the mortality in case of heart failure. You remember, right? There are only some set of drugs which reduces the mortality in heart failure. Like one is beta blockers, another one is ACE inhibitor or ARBs, another one is spironolactone. And anybody? The valsartan and sacubitril combination, which is being recently approved. And fifth drug is the fixed drug combination of the isosorbate dinitrate and hydralazine. So these are the only 5 drugs which reduces the mortality in heart failure patients. So remember here, beta blockers, ACE inhibitors, spironolactone, all these 3 things causes hyperkalemia. The 6th drug is the SGLT2 inhibitor. So these are 6 drugs which inhibits the mortality or reduce the mortality in chronic heart failure. So among these 3 drugs are very important in causing hyperkalemia. So many of the patients of chronic heart failure therapy are usually receiving the combination of a beta blocker or ACE inhibitor or a ACE inhibitor or a ARB or a beta blocker. So these combinations are very, very important, and even fixed drug combinations also come in the market. So you need to have a special interest in monitoring potassium in these particular patients. So that's why some combinations are never recommended, especially combining ACE inhibitor and ARBs is never done. You cannot see a patient receiving both telmisartan and ramipril simultaneously in your day-to-day practice. If at all that patient is receiving both the drugs together, you need to monitor the potassium daily. So this is a rule. You cannot use these combinations. If at all you are using, especially some studies have shown that the addition of ACE inhibitors and ARBs reduces the proteinuria much in case of diabetic nephropathy rather than using a single drug. So some physicians or some nephrologists tends to prefer the combination of ACE inhibitor and ARBs. So whenever this combination is being used, you need to suspect hyperkalemia or monitor hyperkalemia. And ACE inhibitors are never combined with the spironolactone for the risk of hyperkalemia. Again, this is very, very important. So apart from the renal insufficiency and the drugs, the next common causes are next causes are the very less common. We usually don't see in day-to-day practice. These are only for exam purposes. So the hypoaldosteronism, any amount of hypoaldosteronism can cause the hyperkalemia, because we know that the aldosterone is a very, very important hormone which causes the sodium reabsorption and potassium secretion. So whenever this aldosterone is not there in the body, so this can cause the reduced excretion of this potassium into the urine, can cause hyperkalemia directly. So where this primary hypoaldosteronism can occur. So any kind of primary adrenal insufficiency. So this primary adrenal insufficiency is very, very common in India, especially because of chronic infections due to tuberculosis, HIV, all these things can cause adrenal insufficiency, and autoimmune adrenal destruction as a part of isolated adrenalitis or polyglandular syndrome, or some tumors, meningococcal infections. You might have heard that specific syndrome, that is Waterhouse-Friderichsen syndrome. So all these acute entities where there is an adrenal insufficiency, where there is a reduced secretion of both corticosteroids and mineralocorticoids can cause the hypoaldosteronism. Again, the congenital adrenal hyperplasia by the 21 hydroxylase deficiency can cause hyperkalemia. We know that the usual enzymes which are involved in CAH are the 11 alpha hydroxylase, the 17 alpha hydroxylase, and 21 alpha hydroxylase. So this 11 and 17 hydroxylase enzyme deficiencies usually causes hypokalemia and hypertension, whereas the 21 alpha hydroxylase deficiency is the only thing which causes hyperkalemia. So whenever you have got a case scenario in the exam, to differentiate between the 11 alpha hydroxylase and 17 alpha hydroxylase versus the 21 alpha hydroxylase, you need to look at the potassium. If the 11 alpha hydroxylase is deficient, then the patient is going to have hyperkalemia. This is very, very important. And then there are specific entities where there is an aldosterone synthase, which is a particular enzyme which is being required for the synthesis of mineralocorticoid is deficient. So this is a very rare entity where this particular enzyme itself is deficient, can cause hypoaldosteronism. And then the secondary hypoaldosteronism, where the cause is in the pituitary or the hypothalamus due to reduced ACTH secretion, can cause the hypoaldosteronism, which is secondary. Then there is hyporeninemic hypoaldosteronism. We know that aldosterone secretion is under the control of renin. Whenever there is a reduced renin secretion, this is going to cause the hypoaldosteronism and the hyperkalemia. So which is being seen in renal dysfunction, any amount of renal dysfunction due to atrophy of this juxtaglomerular cells, especially in case of diabetes mellitus. So if you search any textbook or any Google, indeed, if you put the word called as hyporeninemic hypoaldosteronism, the first thing which comes is the diabetes mellitus. The next are the drugs, the NSAIDs and the cyclosporine by unknown mechanisms. The NSAIDs, again, by reducing the prostaglandin synthesis, as I told you, these three are the very, very important reasons in causing hyporeninemic hypoaldosteronism. This is very, very important. Then there are some entities of pseudo-hypoaldosteronism. Why it is called pseudo? So what is hypoaldosteronism? We know that hyperkalemia and metabolic acidosis is hypoaldosteronism. Hypokalemia with metabolic alkalosis is hyperaldosteronism, whereas hyperkalemia with metabolic acidosis is hypoaldosteronism. So hypoaldosteronism, if it is there in the background of normal aldosterone secretion, then it is called as pseudo hypoaldosteronism. That means there has to be a defect in the channel. So there are two types of this pseudo hypoaldosteronism. There have been a lot of complication explained mechanisms, complicated mechanisms being given in the textbook. I have tried to make simple here. In type 1, there is type 1A and type 1B, and there is type 2. Type 1A can be autosomal recessive or autosomal dominant. In type 1A, autosomal dominant type, the mutation is there in the mineralocorticoid receptor. We know that there is a principal cell. The mineralocorticoid receptor is situated on the nucleus, and which makes its action by acting on the ENaC channel. So when the mutation is in the mineralocorticoid receptor, then it is autosomal dominant type 1A. When the mutation is in this ENaC channel, then it is autosomal recessive type 1B. So if the defect is in the mineralocorticoid receptor, then this dysfunction is only limited to the kidneys. And when the patient reaches the adulthood, they usually tend to behave normally, or the self-improvement is going to show. If the defect is in the ENaC channel, that is the autosomal recessive type, here the dysfunction is very widespread. The colons and the salivary glands, all these are going to express this mutation. So these patients are usually seen having lifelong salt wasting, hypotension, and hyperkalemia, and these patients usually does not survive. So type 1A is autosomal dominant, the receptor in the proximal part, that is mineralocorticoid receptor. The type 1B is the receptor in the mutation in the ENaC channel receptor. The type 2 here, it is a very complicated mechanism actually. It is mutation in the WNK1 or WNK4 which causes gain of function of mutation of this channel called NCC. So you might have heard this particular channel during the reading about the diuretics. So this is the same channel where the thiazide diuretic acts to inhibit the sodium absorption. So this distal convoluted tubule expresses particular channel called sodium chloride channel. So here this is the same channel which gets inhibited by the thiazide diuretics. So if the gain of function mutation of this particular channel is being occurred due to mutation in the WNK, there is lot of reabsorption of the sodium and the chloride. So along with this sodium chloride, lot of potassium is also going to be reabsorbed due to electronegative charge of the excessive chloride that is getting absorbed along with the sodium. So these patients are usually having hyperkalemic hypertension. So among all the causes of hypoaldosteronism, the pseudo-hypoaldosteronism type 2 is the only one which is having hypertension. Otherwise, hypertension is not seen in any hypoaldosteronism because there is normally sodium wasting occurring in these patients. Whereas the pseudo-hypoaldosteronism type 2, that is Gordon syndrome, is the only one which is seen to have the hyperkalemia along with the hypertension secondary to increased sodium absorption. I think you will study in detail while you studying the endocrine section of all these channelopathies. But for the sake of hyperkalemia, I have taken these discussions here. So again, the congenital adrenal hyperplasia is the very important reason we know due to 21 alpha hydroxylase, and constipation. We know that colons are also the rich source of the potassium secretion. Since in the constipation, the colon is not secreting this excess potassium into the stool. So whatever the excess is there in the colon cells is getting reabsorbed into the circulation, causing hyperkalemia. This is also very, very common. The chronic constipation is also a reason for the unexplained hyperkalemia in the patient. So this particular slide is a very important slide which you should revise before going to any entrance exam. That is the drugs causing the hyperkalemia. We know that beta blockers, NSAIDs, ACE inhibitors, and ARBs. So aliskiren is again a direct renin inhibitor. Again, it is inhibiting the renin, causing hypoaldosteronism. Then heparin and ketoconazole, they directly reduce the aldosterone synthesis, as I explained you. Then mineralocorticoid receptor blockage, that is caused by spironolactone and epinephrine. Then ENaC blockade is being done by the drugs called amiloride and the triamterene, trimethoprim, the pentamidine, and again lithium. Lithium can also cause hyperkalemia by the same mechanism. The NCC activation, this is been given as a mechanism of the CNS, that is calcineurin inhibitors. The two drugs are the cyclosporin and tacrolimus. Actually, it is not a single mechanism which is causing the hyperkalemia. We know that NCC activation is the same mechanism which is been responsible in pseudo-hypoaldosteronism type 2, that is Gordon syndrome, which channel gets activated by this calcineurin inhibitors can cause hyperkalemia. Then there are some drugs which can cause the shift of this potassium out of the cell, that is alpha agonists, the beta blockers, the digoxin, the succinylchlorine, and some anesthetic agents like isoflurane. Then minoxidil is a sodium channel opener. Then somatostatin. Then some solvent drag effect by mannitol and IVIG, and the hypertonic saline, which are used especially in case of the traumatic brain injury, are notorious in causing hyperkalemia. So this is very, very important slide which you should revise before going into any entrance exam. Then if you see the clinical manifestations of this hyperkalemia, the very, very important are the cardiac rhythm disturbances and muscle weakness. The muscle weakness, I need not tell in detail. The patient are going to have the element type of paralysis, which usually begins in the lower limbs, then ascends to the upper limb, that is ascending type of paralysis. And if it becomes severe, the patient can have a respiratory failure. So this muscle weakness can directly correlate with the potassium value. More and more potassium is there, more and more muscle weakness is going to occur. The very important thing which you should remember is the cardiac disturbance. So this cardiac abnormalities are usually seen when the potassium are more than 6. So this is again an entrance question. The amount of serum potassium which is usually seen in a patient of rhythm disturbances is usually potassium of more than 6. Then there are sequential changes which are going to occur in the patient. So this sequence, first there is a repolarization abnormalities. Then there is a depressed intracardiac conduction. We know the normal ECG. So this P wave is an atrial depolarization. The QRS is a ventricular depolarization. T wave is a ventricular repolarization. So whenever the hyperkalemia is seen in the patient, the first thing is the repolarization abnormalities. So repolarization abnormalities we usually see for the abnormalities in the T wave. Then if the hyperkalemia gets prolonged, then there is a reduced intracardiac conduction. This is very, very important. So this reduced intracardiac conduction can manifest in a variety of arrhythmias, where it can manifest as sinus bradycardia, the sinus arrest, then slow idioventricular rhythms. Again, this is very, very less common. Then patient can have serious arrhythmias like ventricular tachycardia or ventricular fibrillation or asystole. This is also very, very important. And this is actually very important cause of death in the patient of hyperkalemia, that is asystole, that is called as cardiac standstill, where the heart stops in diastole. So again, entrance question, in hyperkalemia, heart stops in systole or diastole? The answer is diastole because of repolarization abnormality. So the variety of arrhythmias, especially the bradyarrhythmias, are very, very common in case of the hyperkalemia. So if you see the sequential changes, the first foremost important things are the peaked T waves. Then after this, the conduction defects are going to appear, where there is a reduced P wave size, the PR prolongation, where eventually the P waves might disappear. So if this again gets prolonged, can cause the high-grade AV block with slow junctional or ventricular escape rhythms. Then it can cause the prolonged QRS interval and bizarre QRS morphology. If you see any patient which is not being explained by any intracardiac abnormality, you need to suspect the potassium abnormalities. That is the rule actually. And if it is not getting relieved, then the patient is going to have this particular sine wave appearance. Sine wave appearance is nothing but your QRS is getting prolonged and it is going to merge with the T wave. So this is called sine wave. You might have learned in the physics. So this is a sine wave pattern. This is a pre-terminal rhythm. If the patient is in this rhythm, the next thing you are going to see is the flat ECG. So this is a very, very important thing. The sine wave appearance is seen in which electrolyte abnormality is also a very common question. It is seen in hyperkalemia. This is usually because of this QRS goes on prolonged and eventually this ST segment disappears. This gets combines with the T wave. Where the first change that appear is the peak T wave. This is very, very important. So before going to see this T wave abnormalities in the ECG, we need to know what is a normal T wave. What is a normal T wave? Normal T wave is upright, except in lead AVR and V1, sometimes in lead 3 also. But in AVR, V1 it is inverted, otherwise it is upright. And normal T wave is asymmetric. If you see normal T wave, you see here, the upstroke is very slow, whereas downstroke is very quick. This is a normal T wave. This is very, very important thing to remember. The normal T wave is asymmetric. And also, what is the normal amplitude of the T wave? Normally, it is less than 10 mm in case of the precordial leads or chest leads, or less than 5 mm in case of the limb leads. Although this is not a strict rule, because the T wave voltage always depends on the pre-existing QRS complex. For example, in case of the left ventricular hypertrophy, the complexes of QRS are very of high voltage. The T wave may also gets increased in the voltage. So again, but the basic rule which we usually follow is less than 10 mm in case of chest leads and less than 5 mm in case of the limb leads. So normal T wave is upright, normal T wave is asymmetric with a very gradual rise and a very sharp fall. and normal T wave is less than 10 and less than 5 in leads. So see this ECG. What is there in this ECG? If you see, actually there are tall T waves. So is it hyperkalemia? So if you actually read this ECG, what is the rate? The rate is pretty low. I think it is less than 50. What is the rhythm? Is rhythm sinus? Yes, rhythm is sinus. How to tell rhythm is sinus? The P wave should be upright in all the leads except in AVR, and every QRS complex should be preceded by a P wave. Then it is only sinus rhythm. Yes, it is sinus rhythm. What is the axis? Axis is normal. So what abnormality you are seeing in this particular ECG? So if you look carefully, there is actually an ST elevation in V1, in V2, in V3. And again, V4 is also showing some ST elevation. So is it ST elevation MI? No, this is not an actually ST elevation MI. See this ST. See the ST segment, especially in case of the V4 and V3. So this is like this, concave upwards. This is very, very important. So this is concave, isn't it? So there is a rule actually. MI, it is usually, in case of an MI, it is convex upwards, whereas in case of benign lesion, it is concave upwards. So this concave upwards is usually a benign entity. And if you see the T wave, they are pretty large in the amplitude. But if you see the preceding R wave also, which has increased in the particular amplitude. So, and if you also see, there is a notching in the J segment here, or ST segment. So this is a very typical of what you call as the early repolarization changes, or the benign repolarization, or J point elevation. So this is not a hyperkalemia, although if you see the directly, you can see some bradycardia, you see some large T waves, but this is not a hyperkalemia. And T waves are also normal. You see the normal slow upstroke and very fast downstroke is also maintained in this. So this is a benign electrical rhythm. So see this ECG. So here there is tachycardia. I think there is an LBBB with a very prolonged QRS and very large T waves. So you can suspect hyperkalemia when you directly see this ECG. But if you see the QRS length is also very high. The background of left ventricular hypertrophy is also there in these patients. So this is not a tall T wave. That is what I'm going to confirm here. So this is not called as a tall T wave. Although if it is called as a tall T wave, it is considered as normal repolarization abnormality along with the background of LBBB. This is not an abnormal T wave. See this T wave. Here, the T wave is very tall and the normal asymmetry is gone. The T wave has become very symmetrical. T wave has become very pointed and the base is very narrow. So this looks like an Eiffel Tower. So this is a very typical of hyperkalemia. How will you describe the hyperkalemic T wave? It is tall, it is symmetric, and it is narrow base. This is very, very important things I am telling you, very hard to get in usual textbooks, and you might end up committing mistakes in day-to-day practice if you don't know these basic things. So hyperkalemic T wave is tall, hyperkalemic T wave is symmetric, and hyperkalemic T wave is narrow base. And here these changes are not territorial. This is seen in almost all the leads. Okay. Whereas there is something called as a hyperacute T wave of an MI. You might have heard this terminology because hyperacute T wave is the first thing to occur in case of an ST elevation MI. See this T wave. This T wave is tall, yes. Symmetric, yes. This kind of pretty symmetric. But the base is very broad. So this is very, very important. There is a broad base. This is not hyperkalemia. The base you should look. to differentiate between tall T wave of the hyperkalemia versus the tall T wave of the acute MI. So if you see the difference between these, both are tall, but the hyperkalemia, it is narrow based, whereas the MI, it is broad based. It's symmetrical in case of hyperkalemia. It can be asymmetrical or it can be symmetrical in case of an acute MI, and they may often precede the ST elevation or an abnormal Q wave or pathological Q wave. And these changes are seen in all leads, whereas these changes are usually territorial. For example, if you are having an anterior wall MI, the changes are seen only in the anterior leads. If there's a lateral wall MI, the changes are seen only in lateral leads, and same with the inferior leads. So this is very, very important. So if you read this particular type of ECG, so broadly looking, there are no P waves. I cannot see any P waves here. There is some amount of RBBB morphology, the T wave inversion, and T waves are very pointed. So this is called a pseudo RBBB pattern. Where is this seen? Pseudo RBBB pattern. This is seen in Brugada phenocopy. This is also called as Brugada phenocopy. So this hyperkalemia can also cause Brugada phenocopy. How will you differentiate this Brugada phenocopy with Brugada syndrome with the hyperkalemia induced Brugada phenocopy? This is by the absence of the P wave and other changes of the hyperkalemia. That is, tall T waves are not usually seen in case of Brugada syndrome. See that T waves are very pointed here. So this is not seen in Brugada syndrome, and P waves are absent here. So P waves are normal in case of Brugada syndrome because the management is entirely different in case of Brugada and in case of hyperkalemia. You need to rule out potassium in every abnormal ECG you see in day-to-day practice. So see this QRS complex. So this is RSR pattern. So RSR pattern, we usually end up telling that patient is having RBBB, but this is not RBBB because if you calculate the QRS complex here, calculate the duration of QRS complex, it is almost near to 200 milliseconds, which is impossible in case of an RBBB. So any bundle branch block with a bizarre QRS complex, very unexplained pathology, if you're seeing, you need to suspect hyperkalemia. So what I'm trying to tell here is any abnormal ECG, you need to correlate the patient with the clinical background and always have a look of potassium before alerting the cath lab or before sending the patient to other departments for the management. So potassium, you need to be very careful with the ECG in the background. So again, if you see the patient here, this is a baseline ECG. This particular picture I took from Dr. Smith ECG blocks, which I usually follow for the ECG. So this is a patient with a background normal baseline ECG presenting with an emergency with a dyspnea. See this ECG, there is a bradycardia. If you see this ECG, the T waves are not tall actually, but they are pretty tall compared to the background QRS. And this patient, after some time, the change in the monitor, repeat ECG was taken. See the change in the amplitude of this T waves. So this is what happened when the potassium is not being addressed. So this patient was thought to have some sinus block or some bradycardia or MI. So the patient is going to have a dynamic changes in the ECG similar to the MI. So this is actually hyperkalemia, but not an acute MI. So this is very, very important. So any patient, you need to rule out the hyperkalemia with abnormal ECG. So with the evaluation, it is similar to hyperkalemia. First and foremost thing is the history and physical examination. Rule out very important drugs. Physical examination, see which patient has hypertension, which patient is volume deficient, which patient is salt deficient. All this is very, very important. The routine lab test rules out 50% of the disease. By the time you see creatinine, if you see very high rise in creatinine, and hyperkalemia is very easily explainable with anything. Now, all things like history, physical examination are normal, the routine blood tests are normal, then you need to see the urinary potassium excretion by calculating TTKG. In the last class, we discussed what is TTKG, that is transtubular potassium gradient. It is actually the gradient of the amount of potassium in the lumen of the distal tubule and the lumen of the peritubular capillaries, so which predicts the amount of secretion of this potassium into the cells. So this is a very interesting algorithm for the evaluation of the hyperkalemia patient. So whenever you see a patient of hyperkalemia that is more than 5.5, the first and foremost thing is to see the ECG changes. If there are ECG changes, you need to go for immediate therapy. You need not waste time in actually diagnosing the patient. And before doing that, always rule out the pseudo-hyperkalemia by taking the repeat samples and correlating clinically. And again, look for some intracellular shift mechanisms like the hypertonicity, hyperglycemia, drugs, all these things you need to rule out. And if no extracellular shift is documented and pseudo-hyperkalemia is ruled out and no urgency in the management, then you need to calculate the urinary potassium excretion. So if this urinary potassium excretion is decreased, then you need to calculate the other urine electrolytes. If along with the potassium, if sodium is also low in the urine, that means the distal flow itself is low. So these patients are usually having this CKD and all these things. And to differentiate between other causes, you need to calculate the TTKG. If the TTKG is increased, that is, if it is more than 8, that means the tubular flow is being reduced. So this is an actually advanced kidney failure, or the patient is having reduced extracellular volume. If the TTKG is reduced in the patient of hyperkalemia, so that means the excretion of the potassium itself is low. So to know whether it is a case of the tubular dysfunction or the hypoaldosteronism, you need to assess the response to the fludrocortisone. If fludrocortisone it is resistant, then it is either some drugs or other causes like pseudo-hypoaldosteronism or the other causes like hyporeninemic hypoaldosteronism, all these things I told you. And if the TTKG is increased after giving the fludrocortisone, then the patient is aldosterone deficient. To know whether it is hyporeninemic or hyperreninemic, you need to estimate the renin and aldosterone ratio. If there is increased renin and the low aldosterone, then it is primary adrenal insufficiency and all these things. And if there is hyporeninemic hypoaldosteronism, I think we discussed the causes in the class. And the treatment of hyperkalemia is very, very important. Every doctor should know how to manage hyperkalemia. We need to know what is the urgency in the management. If there are ECG changes, if there is muscle dysfunction, if there is paralysis, if there is acute acute increase in the hyperpotassium level, you need to manage patient very urgently. And if there is a chronic or persistent hyperkalemia, then we need to go for non-emergency management. In emergency management, the first and foremost thing is the myocardial stabilization. First is prevent the cardiac arrhythmias by giving the calcium gluconate. The calcium is an antagonist to the hyperkalemia-induced persistent depolarization. So it is the first priority in all the patients of hyperkalemia with ECG changes. So this is being achieved by giving 10 ml of 10% calcium gluconate, which is given over 5 to 10 minutes. So whenever you see a hyperkalemia patient, especially with the ECG changes, the first thing you will order is to give calcium gluconate or push calcium gluconate. But remember, this is neither going to shift the potassium to the cell nor going to eliminate it from the cell. Total body potassium is going to remain normal, but it just reduces the myocardial destabilization or arrhythmias which are occurring. You can repeat the dose if it is required. And this is being given till the normal sinus rhythm is achieved in the patient. And the onset of action is very, very immediate, and duration is still half an hour. So you can repeat the dose after half an hour. And you need to avoid this IV calcium in a patient of hyperkalemia who is on distalis. Especially the distalis toxicity has been suspected. The best line of treatment is going for a digibind, which is monoclonal FAB fragment, which is being used in the distalis poisoning, or you can straight away dialyze the patient. The IV calcium, sometimes it is earlier believed that it is going to increase the effect of digoxin, but nowadays everybody is being believed that it is not been harmful, but it is useless also. So even if you give calcium to this digoxin patients with hyperkalemia, it is not going to regularize the rhythm, because the calcium is going to have agonistic action with the digoxin. And after giving the calcium gluconate, the next thing you are going to give is the drugs which shifts the potassium into the cell, that is the insulin. So you cannot give just insulin because it can cause hypoglycemia in the patient. So it is given along with the dextrose drip. You can use either 25% dextrose or 50% dextrose, which is pushed with a 10-unit regular insulin. It can cause the shift of this potassium into the cell. So remember to monitor the blood glucose during this insulin potassium drip. So this action begins within 15 minutes and the duration is up to 2 hours. Along with the intracellular shift, the next thing is the beta agonist, especially in the form of nebulization. You are going to give the 10 mg of albuterol nebulization to the patient along with the insulin drip to move the potassium into the cell. Remember the dose, it is 10 mg, whereas if you remember, whatever the dose which we usually use for bronchial asthma management is very low, that is 2.5 mg. Here it is 4 times more dose which we are using for the hyperkalemia management. So dose is not same. I have seen many doctors giving the advice of nebulization, 1 ampule, 1 respule, 1 pulmule, all these things. This is wrong. The dose is actually 4 respules. So that means 1 respule contains 2.5 mg. That means the 10 mg. So 10 mg of albuterol or the Astelin nebulization is given. And the bicarbonate is a controversial one. Many of the nephrologists don't believe the bicarbonate in reducing the or moving the potassium into the cell. So some textbooks do consider bicarbonate, but some textbooks also omit the bicarbonate as a management of the emergence hyperkalemia. And as usual, when you are giving insulin, you avoid hypoglycemia in the patients. So this is very, very important. So whenever you see a patient of hyperkalemia with the ECG changes, first and foremost thing is the calcium gluconate, then give the patient insulin, then give the albuterol nebulization. This is very, very important. Then try to eliminate the excess potassium by giving loop diuretics if the kidney function is normal. You cannot give in case of end stage kidney disease where the kidney function itself is lost, where loop diuretics are very resistant. The loop diuretics are going to act on the cells of the kidney. These cells are itself gone, so loop diuretics become useless sometimes in case of the end stage kidney disease, where you might end up in giving in doing the hemodialysis for the urgent management. And the K binders, that is potassium binders, where they eliminate this excess potassium in the into the stool. These are usually not used in case of an acute hyperkalemia management. They are mainly used for chronic hyperkalemia management. Acute hyperkalemia, they are usually not advocated. The very next thing you do after the patient who is not responding to the calcium or insulin glucose infusion is to take him on the emergency hemodialysis as a rule. So if you see the chronic hyperkalemia, where hyperkalemia is persistent due to some conditions like pseudo-hyperaldosteronism or hypoaldosteronism or diabetes mellitus or the CKD itself, you need to keep the patient on low potassium diet. This is a very first order which we usually advise for a CKD patient where he is dropping GFR. Don't ask them to not to consume any fresh fruits, coconut water, banana, etc. So recommended amount is the 2 gram or 550 milliequivalents per day. And review these medications. So I have told you what all the medications which can cause hyperkalemia. All those drugs has to be stopped if possible, or the dose has to be reduced if possible. Then the potassium binders are used. So they are considered in patients with the persistent hyperkalemia in spite of all dietary interventions. Even if you have done the low potassium diet, patient is on chronic hemodialysis, the drugs have been reviewed, although potassium is not getting controlled, then you are going to give the patient the potassium binders. So they can also be used in conditions with strong indications for some drug causing hyperkalemia. Like if you have got some condition where the drugs which can cause hyperkalemia are must, like ACE inhibitors in case of diabetic nephropathy. You cannot stop ACE inhibitors, so you can add the patient along with the drugs causing hyperkalemia, the potassium binders. So there are three types of potassium binders available in the market. The old one was the sodium polystyrol sulfate, that is SPS. Then there are other two new drugs, that is patiromer and sodium zirconium cyclosilicate. The drugs which are recently approved have come into the market. So this again is the entrance question. I think 2 years back this question appeared, which is the latest calcium binder or hypocalcemic drug that is approved by the FDA, that is sodium zirconium cyclosilicate, which is approved in the 2019 FDA. So SPS, we know the very famous trade name was the Caxilate or the K-bind sachets, which usually we use in case of day-to-day practice. So it is actually an exchange resin. So this is a resin which actually exchanges the cations. So what it exchanges? It exchanges sodium for the potassium. So whatever the sodium is there, it is going to give. So whatever the potassium is there, it is going to absorb. So you know this is a sodium polystyrol sulfonate. So this sodium is going to come out and potassium is going to bind. So this is getting excreted in the urine. So this was a very old potassium binder. So initially it was believed that when it was given along with the laxatives or cathartics, the effect was the more pronounced, the hypokalemic effect. That's why initially it was given along with the sorbitol, which was a cathartic or a laxative. So then there appeared the case reports of this colon necrosis with the use of this SPS. So this SPS, there are some FDA warnings they gave. The colonic necrosis or colonic damage caused by this SPS is not by the sodium polystyrol sulfonate. It is actually because of the sorbitol, which is being used along with the SPS. So the dose is usually 15 to 30 gram orally, or the 30 to 50 gram used as a retention enema. So if you see this black box warning of the FDA, the colonic necrosis cases of intestinal necrosis, which may be sometimes fatal, or serious gastrointestinal bleeding have occurred in case of Caxilate use. So do not use in patients who do not have normal bowel function, like if the patient is chronically constipated, if the patient is having a more risk of the vascular disease like inflammatory bowel disease, ischemic colitis, atherosclerosis, or previous bowel resection or bowel surgery has been done, or patient presently in a post-operative period with the hyperkalemia, you cannot use this SPS. This is a very, very important black box warning. So you cannot use this patient in case of constipation, and don't give the repeated doses if the patient have not passed stools. This is a very, very important. So what we actually do in day-to-day practice, because the newer drugs are too costly, and if the patient is using this SPS, we are usually giving SPS with the water. So if SPS with water is not giving adequate response, then you can use first 33% sorbitol, that too in a non-risk category, that patient is not constipated, patient is not in a post-operative period, patient does not have any risk of the bowel abnormality. So you can use 33% sorbitol with SPS. Even if this is not going to respond, it is better to go for the newer drugs. If the newer drugs are not available, then the last option is the 70% sorbitol with the SPS in reducing the potassium. So, you know, patiromer is a recent drug which was approved in 2015. So here it exchanges the calcium for the sodium. So in SPS it is sodium, in patiromer it is calcium. Here it takes some hours to take the set of the action. And here, since it exchanges the potassium and also magnesium along with the calcium, the patient needs to be monitored for the hypomagnesemia. And constipation is the usual side effect which you usually see. The patiromer is administered from not mixed with other medications, because it significantly reduces the absorption of drugs like metformin, the thyroxine, and the drugs like ciprofloxacin, levofloxacin, and all these fluoroquinolones. The drugs are reduced. The absorption is reduced. So the starting dose is the 8.4 gram, and you can increase the dose by 3 times to 25.2 gram per day to achieve the recommended target level. And this patiromer in some studies have shown the additive beneficial effect in case of the diabetic nephropathy due to its action in reducing the proteinuria also. So this can be an entrance question in the future coming years. Among all the calcium binders, which calcium binder has shown the beneficial effect or more effective in case of the diabetic neuropathy? This is because this is the patiromer. So the trade name is the Valtessa. I think I have not used till now this because of the cost. This is very costly and availability is also being the issue. We are still using the K-bind sachets. And this is a low calm, that is sodium zirconate cyclosilicate. It was approved in 2018 and 19. Then it exchanges the potassium with the sodium and the hydrogen ion. Here it is the onset of action is pretty early compared to other potassium binders. And again, this is a risk of binding with other drugs. There has to be a gap of 2 hours. And the starting dose here is the 10 gram, which can be given 3 times today up to 48 hours. So if you see the comparison, the mechanism of action is in the SPS, it is non-specific cation binding in exchange of sodium. Here it is a polymer exchange resin patiromer which exchanges for the calcium. Whereas sodium zirconate cyclosilicate is a selective potassium binder in exchange of sodium. The time to normal kalemia is unconfirmed in case of the SPS, whereas it is within 1 week in case of patiromer, and median 2.2 hours. A very fastest mechanism of action is seen with the SZC, that is sodium zirconium cyclosilicate. So this is a very fastest acting hyperkalemic agent used in management of hyperkalemia. This can also be the entrance question in the coming years. So the onset of action is generally hours to days. Here it is 7 hours. It is 1 hour. This is very fast. And again, the drug interactions are very common, especially it is very high with the SPS, where it is pretty low with the sodium zirconium cyclosilicate. The location of potassium binding, it is only in the colon in case of SPS and the patiromer, whereas it can bind to the entire potassium in the GI tract. So the safety and tolerability concerns were the issues with the SPS, whereas the GI side effects are very mild in case of the sodium zirconium cyclosilicate. The only adverse effect was the edema because of the sodium content. So, but pretty GI safe agents are these two drugs. So this is again an American Journal of Nephrology algorithm for the management of hyperkalemia. The acute first is giving calcium, then give the insulin glucose drip, then the salbutamol nebulization, that is 20 gram here they are giving, but the minimum dose is 10 gram. Then after that, the diuretics, that is loop diuretics and hemodialysis and the sodium bicarbonate. In some cases, especially in the background of acidosis, you can use. If not responding, then only the K binders are used in case of acute. In case of chronic, the first thing is the diet counseling. Next is manage the RAS therapy. Then effective diuretic therapy, then oral sodium bicarbonate, which are usually used in case of the CKD, soda bicarb. Then the potassium binders are used in case of, this is a multidisciplinary management in case of chronic hyperkalemia. So if you see some questions, the hyperkalemia can occur in all except the insulin deficiency can cause hyperkalemia. Metabolic acidosis can cause hyperkalemia. Acute renal failure can cause hyperkalemia, whereas Cushing syndrome is a cause of hypokalemia. It is Addison's disease which is causing hyperkalemia in the patient. All of the following are used for the treatment of hyperkalemia except, see, this is a calcium gluconate is used, the sodium bicarbonate is used sometimes, but not used sometimes. Beta blockers are not used because they are the cause of the hyperkalemia. And IV infusion of glucose and insulin is used. So it is the beta blockers which are not used in the treatment of hyperkalemia. All of the following may occur due to hyperkalemia except prolonged PRS interval. Yes, it can occur. Prolonged QRS interval, it can occur. Ventricular arrest systole can occur. Prolonged QT interval is not a feature of hyperkalemia. It is a feature of hypocalcemia. So I think I have discussed all the dyselectrolytemias in the last 1 or 2 months. So there is a message here. There will be always a progressive widening of QRS sine wave plus VF plus asystole plus axis deviations plus bundle branch blocks plus vesicular blocks in patients of potassium more than 8. The spurious hyperkalemia should be treated with tight tourniquet and hemolysis and thrombocytis. I'm not understanding this question. May I contact you in WhatsApp if possible? Yes, you can definitely contact me in the WhatsApp. I am always available to guide the students in the whatever way I can. So, and rather recently, I think I went through the article, I think few months back in the American Journal of Emergency Medicine, where they published an article regarding the myths of the hyperkalemia. In one of the myths, what they mentioned is the ECG changes does not correlate with the potassium level. This is a very, very important regarding the recent advances of the hyperkalemia, because you see all of the textbooks tend to mention this particular slide, like for this level, these are the changes for this level, these are the changes for this level, these are the changes, all these things, like there are sequential changes. Yes, this is true for some part, but there are some patients even with a very high potassium, like potassium may be very like 9, 8, there are case reports, but even without a single ECG change. So the cardiac rhythm disturbances or abnormalities may not, I'm not telling does not, I'm telling may not correlate with the serum potassium level. So this is a recent advance as far as the things regarding hyperkalemia. And again, the other recent advances are the famous questions regarding the new K binds that are being into the market, and the colonic side effect of this Caxylate or K bind sachets, and how to use this to reduce the colonic side effects is also very, very important. So thank you very much for all the section. I congratulate this White Army and students for making it one of the popular website in the medical field. Like 1 lakh subscribers, it is not a small thing to achieve, being a selfless service. And I congratulate again Dr. Kishan and all the mentors and all the students for making it successful, and may it grow well and benefit the students. What is the best drug if entry-wall MI plus hyperkalemia? Again, entry-wall MI with hyperkalemia, you need to push the patient calcium gluconate, do the insulin, whatever the things you're going to do, you can do it along with the management of entry-wall MI. That is, you can consider the patient for thrombolysis. You can also consider the patient for stenting along with the management of hyperkalemia. But if you ask me among these two, I will first manage the hyperkalemia because it may not take much time. Giving calcium gluconate and giving insulin infusion may take hardly 20 to 30 minutes. So it is just by the time you prepare your cath lab for the emergency angiography or angioplasty, you can give these injections to reduce the potassium. Thank you, and thank you all for the fine listening.
Thank you so much, sir. It was indeed a very comprehensive and very extensive class, starting from your class like approach to dyspnea, then diabetic ketoacidosis, then acid-base disorders, then these electrolyte imbalance classes like hypercalcemia, hyponatremia, and now hypo and hypercalcemia. Each and every class is so useful for us, sir. We are so grateful to you, and we need your support and guidance throughout, sir. Thank you so much.
Thank you very much. And if at all anybody needs any guidance, I'm always available. And if any group of students are interested in dealing with particular topics, if you guys want me to deal with some particular topic related to internal medicine of any specialty, I will be ready. So, and for any case presentation, I will be ready at any time. So you can contact Dr. Kishan, or you can contact me also for the whatever the help which is being possible with me. I will be available anytime. Okay, thank you. I need to rush to OPD, so I need to log out this. Okay, thank you.